Welcome to The Explainer. Today, we're doing a deep dive into a condition that affects millions of people but is still so often misunderstood: chronic venous disease. We're going to break down the latest clinical guidelines to give you a really clear, evidence-based roadmap for diagnosis and treatment.
So here's our game plan. We'll start with the basics, get on the same page. Then we'll look at the biology, what's actually going wrong in the body. And then we'll spend the bulk of our time on the two most critical parts: how to nail the diagnosis and the full spectrum of treatment options available today. All right, first things first. Before we can talk about treating it, we have to establish a really clear, shared understanding of what chronic venous disease, or CVD, actually is. You know, a lot of people hear CVD and just think varicose veins, but it's so much more than that. This definition is key because it frames it correctly. This is a long-term pathological condition. The veins themselves are anatomically or functionally broken, and that leads to a whole cascade of problems. This elevates it from a simple cosmetic issue to a true medical condition that demands our attention.
So how do we talk about this clinically? Well, this is where the CEAP system comes in, and it's basically the universal language for venous disease. It's an incredibly powerful tool. You can describe a patient's entire condition with a simple code. For example, C3EPSP. That tells me instantly that the patient has swelling or edema. The cause is primary, meaning they weren't born with it. It's affecting the superficial veins, and the underlying problem is pathologic reflux. See how much info is in there? It's absolutely essential for accurate treatment planning.
And who gets this? Well, a ton of people. It is incredibly common, and you can see it's more prevalent in women. The risk factors here paint a really clear picture. It's a mix of things you can't control, like genetics and age, but also hormonal influences and mechanical stress on the veins. And I want you to pay special attention to that last one: a history of DVT. That is a major red flag because it often leads to a much more severe secondary form of this disease. Okay, so we know what it is and who gets it, but why does it happen? To really treat this effectively, you have to get down to the root cause, to the biology of what's going wrong. At its heart, the core problem is something called venous hypertension. You can really just think of it like high blood pressure, but specifically in your leg veins. This high pressure happens for two main reasons. Either blood is flowing backwards, that's what we call reflux, because the little one-way valves inside the veins have failed, or there's a blockage, an obstruction. In primary CVD, the valves just kind of wear out over time. But in secondary CVD, something else, usually a past blood clot, has physically damaged the plumbing. All right, now we're getting to the really critical part: diagnosis. And we're going to slow way down here, because getting this right is everything. A precise diagnosis is the absolute foundation for a successful treatment plan. Let's walk through it step by step. So the diagnostic workup is done in tiers, kind of like levels. Level 1 is your starting point. You talk to the patient, you listen to their symptoms, you do a physical exam. But honestly, to really see what's going on inside those veins, you have to move to level 2. And let me be perfectly clear, this isn't optional if you're thinking about any kind of procedure. It is mandatory. Level 3, that's for the really complex cases where you suspect there's a big problem higher up in the pelvis, like an iliac vein obstruction. And that level 2 test? That's the echo-Doppler, or what we call a venous duplex ultrasound. This thing is the absolute gold standard, and for good reason. It's not just a static picture. It's like having a live video feed of the patient's entire venous system. We can see the anatomy, and more importantly, we can see function. We can literally watch the valves open and close, or in this case, watch them fail to close properly. It gives us a precise roadmap showing exactly where the problem is and just how bad it is. So what are we looking for on that ultrasound? It comes down to this one single critical number. During the exam, we'll squeeze the patient's calf to push blood up towards the heart, and then we watch. If the blood flows backwards for more than half a second, more than 500 milliseconds, that's it. That is our objective proof of reflux. It's the smoking gun that confirms the valves have failed. Okay, so you've done the ultrasound, you've clocked that reflux at over 500 milliseconds, the diagnosis is confirmed. Now what? What does this actually mean for the patient? What's the outlook? And what happens if we do nothing? And this is a point that cannot be overstated. CVD is not a static condition. It's not something that just stays the same. It's progressive. Left alone, it gets worse. If you don't intervene, the disease just keeps marching forward. We know from big studies that about 4% of patients will progress to a more severe stage every single year. Symptoms get worse, the skin starts to get damaged, and eventually painful, debilitating ulcers can form. And for patients who get those ulcers, healing them is just the first battle. Look at that recurrence rate. It's shockingly high. And that tells us that just healing the wound on the surface isn't enough. You have to treat the underlying venous hypertension.
All right, this brings us to the payoff, our final and honestly most important section, treatment. We are going to walk through the entire clinical playbook, from the foundational therapies all the way to the most advanced interventions.
No matter what else we do, pretty much all CVD treatment starts right here with compression therapy. It is the absolute cornerstone, especially for managing symptoms and for healing ulcers. How does it work? It's simple, really. It provides external pressure that helps the calf muscle pump blood out of the leg more efficiently, and it directly counteracts that venous hypertension we keep talking about. And the grade we choose is based on severity, usually starting with grade 2 for varicose veins and moving up to grade 3 or even higher for ulcers.
Now, when it comes to active ulcers, listen up. Not all compression is the same. Just throwing on a simple stocking is not going to cut it. The evidence is crystal clear. Multi-layer bandage systems are far more effective. They're designed to provide sustained high pressure that doesn't let up, which is exactly what you need to overcome those high internal pressures that are keeping the ulcer from healing.
Okay, let's talk meds. This is really interesting because the evidence for certain oral drugs is quite strong. Look at FFPM, micronized purified flavonoid fraction. It has a strong grade 1B recommendation for both symptom relief and as an add-on to speed up ulcer healing. So how does it work? Well, it acts on the vein wall to increase its tone, making it less stretchy, and it also calms down the inflammatory processes that cause all that swelling and pain. It's a proven tool in our toolbox.
So what happens when compression and lifestyle changes just aren't cutting it for that main superficial highway, the saphenous vein? Well, the guidelines are very clear. We move to endovenous thermal ablation. This is now the first-line recommendation over traditional vein stripping. And the why here is so important. When you surgically strip a vein, you're tearing it out, and that trauma can actually trigger the body to grow a messy, weak network of new veins. We call that neovascularization. Thermal ablation just uses heat to close the vein down in place, which dramatically reduces that common cause of recurrence.
Now what about blockages way up high, in those big, deep veins in the pelvis? This is a different ballgame. It's a very specific, step-by-step process for a select group of patients with severe symptoms who have already failed conservative therapy. And the key diagnostic step here is intravascular ultrasound, or IVUS. This lets us look at the blockage from inside the vein. If we can confirm a narrowing of more than 50%, then opening that up with a stent can be life-changing for these patients.
Okay, so what about all those other visible varicose veins, the ones that aren't part of that main saphenous trunk? Well, we have other tools in the toolbox for those. Foam sclerotherapy is fantastic for closing down those winding, twisty veins that a laser fiber just can't navigate. And phlebectomy is a microincision technique to physically remove those large, bulging veins right at the surface. These are often used as finishing touches after we've dealt with the main source of the problem. Wow, we've covered a huge amount of ground today, from the basic definition all the way to advanced endovascular treatments. The evolution of these minimally invasive therapies has been a total game changer. But it also leaves us with a big, forward-looking question. Can we start to shift our focus from just managing CVD when it's already advanced to actively preventing its progression? Can we intervene earlier to stop this disease in its tracks? I think that's the future of venous care. Thank you for joining this explainer.